Hello, good afternoon. Thank you all for joining us. This is the Understanding Common Psychiatric Disorders in Children and Adolescents webinar presented by Kids Mental Health Pierce County and Marybridge Children's. We will have this presentation from our child and adolescent psychiatrist, Dr. Mary Catherine Rensko. Just some quick housekeeping. We welcome you to put in the chat your name and the program or organization you are joining us from. You are also welcome to ask any questions in the chat or the Q&A. I'll be helping to monitor that. You're also welcome to come off mute, raise your hand, and ask questions throughout the presentation as well. We will go ahead and get started. So Mary Catherine, I'll let you take over now.
Go. I have to unmute myself. This is Mary Catherine Rensko. I am a child and adolescent psychiatrist at Marybridge, and I function fully within the hospital. So I see kids when they are admitted for a medical complication or psychiatric needs where they're housed on the medical floor or in the emergency room. And this is geared more towards, you'll have to ignore the beeping if you can hear it. Geared more towards caregivers, staff, people that interact in a teaching or coaching or counseling mentality with kids. So not geared as much towards family caregivers, but we're going to go through two parts today. And I put it in a way that I thought made the most sense, but it may not make the most sense to you. So mental status exam is up first, and then we're going to talk about anxiety. And then tomorrow there are two other portions. So I believe this is also going to be recorded. You can jump off if you run out of time and go back and watch portions, go back and review. You'll have access to all the slides. So the first thing we're going to talk about is mental status exam. The way that we think of it, the typical sections, and then what definitions and ways that we may describe phenomenon within a mental status exam. And then Jasmine, I think you have to give me back control for me to be able to click, maybe.
Or you have to present it from share your screen.
I can do that if it's not working anymore.
If not, I can push slides for you. No, you're good.
Okay. So the mental status exam is basically the physical evaluation of mental health care. It is in place of what would be a physical evaluation if someone went in for chest pain, for example, and someone were to listen with a stethoscope. This is that equivalent in mental health care. So it is only the component of what should be a broader evaluation. There are many different reasons why someone's mental health or behavioral health would be evaluated. So mental status exams, mental status evaluations can be different depending on what the scope is of the overall evaluation. It will typically have some pertinent positives. You're not going to necessarily write paragraphs upon paragraphs. You're going to put things that make sense for why you're evaluating them. And then pertinent negatives. So again, things that don't stand out and you have a reason for excluding those. You want people to know that this was not the case when you had this snapshot in time. It can help identify diagnosis. So if someone physically says that they've been very depressed, but upon observation, they do not look depressed, their voice doesn't sound at all depressed, they're smiling throughout the interaction, it might help you to scale down what you're actually going to be treating. It can help clarify diagnosis. So again, sometimes I'm hearing multiple yeses and nos for things. Can people hear? I think it's only a couple people who cannot. This may help you clarify your diagnosis. So if someone comes in with a chief complaint that they're hearing or seeing things then it may not appear that way when you're able to see them. You might be able to explain what's going on and clarify that perhaps they are having an illusion occur where there is actually something there, but their mind is kind of warping it into something else. So an example could be if you saw something out of the corner of your eye and you thought it was a scary monster, but then in fact you looked and it was the outline of a tree. That would be different than nothing there at all and someone imagining that they are seeing something that nobody else can see. It can help track changes over time. So especially if, for example, someone came in and we were concerned that they were delirious, this may show the ups and downs of their cognitive ability and ability to pay attention, track what's going on throughout time, because it could change throughout the day. It could change throughout days over treatment. It can show cognitive decline, and then it could also show a response to treatment. So at the beginning of time, if you helped someone who came in for depression, they may appear in their mental status evaluation to be very, very depressed. They might have kind of a hunched posture. They might look like they're not caring for themselves in terms of showering or brushing teeth or brushing hair. They might look tearful, and throughout treatment, perhaps they look much different at the end. So again, it can just help solidify what you're doing and if they are getting better. The initial mental status exam was created by Adolf Meyer in 1918. It was an attempt at standardizing ways of evaluating people. And it's an ongoing process of standardization because it may look different depending on what organization you're with. So why we do it is it helps to add some level of objectivity. There's always going to be a bit of subjectivity. So I might have a different understanding than someone else because that person, for whatever reason, might just get along better with one of us than the other one. But we wanted some standardization so that when anyone sat down and looked at a mental status evaluation, they would at least know what items they're looking for. It's also required for documentation. So for the billing, to get money for what was provided, for coding to show what service was provided, and then also for documentation that an exam was performed. Sometimes when people are called into court, they may be called to state what the mental status exam was when they were testifying. And it can also track changes again, see if they're getting better or worse. Maybe that something else has occurred that now you need to add to your problem list. So I'm going to just show you some examples of variations. You don't have to look at every bit of this, but these are just examples. So in one instance, I had a 15-year-old female. I was consulted for a comorbid psychiatric illness. She was seen through the pediatrics team for status epilepticus. And I described what she looked like. She had had an EEG, so what her hair looked like because she had just gotten the electrodes off, what her speech was like, her manner of relating, that she was very dismissive of these seizures, didn't think that they were a big deal. However, during the encounter, she was physically moving appropriately, wasn't having any involuntary jerking or anything that would look like a seizure. Orientation-wise, she was with it, she was alert, awake, she knew where she was, as opposed to someone who may have just had a seizure and would be post-ictal and perhaps confused or very fatigued. She was silly, again, a bit odd for her parents being so concerned that she was having seizures. She was pretty flippant about it. Here's another example, a 17-year-old male. I was consulted for medication management because he was involuntarily held in the ER, and he had come for paranoia. So he had good appearance, a little bit of speech latency, meaning it took a little bit for him to respond, as if there was some slowing. He was able to relate. He was pacing, consistently moving his foot. However, he was oriented. His range was restricted. He was smiling kind of at inappropriate times, sometimes fearful at providers or staff. Had some paranoid delusions, but he was not overtly interacting with internal stimuli. He wasn't staring off as if something was there. He wasn't talking to anyone that I couldn't see. And then he had intact concentration. Another example is an 8-year-old male came in because he had told his parents he had hallucinations. So this is particularly important when people disclose things to you to see how much is it impacting them. And then it can drive you to look for other things to see what might be causing hallucinations. So in this case, he was hyperactive, jumping on the bed, knew where he was, knew why he was there, had a linear thoughts. He was able to connect one thought to the next. And when I would ask him a question, he would answer the question directly. He wasn't going round and round in circles. He described no auditory hallucinations, but he said he has a vision sometimes that he can make go away voluntarily. So this is important because you're looking for kind of clues as to what could be causing the hallucinations. At that age, it would be very, very unusual for someone to have something like bipolar disorder or schizophrenia. And the fact that he is otherwise well, able to care for himself, able to have a coherent conversation, know why he came in, has intact concentration. That's probably leading us away from that decision in terms of diagnosis. Can sometimes be multiple mental status evaluations throughout time. So those might change, and that would be appropriate to change because they might have progress, or it could be a different provider who sees that person and they're looking for something different. So this is someone who was dressed appropriately. However, they were shirtless and they were stretching, posing, flexing. They had excited tone of voice. They were speaking very quickly. However, you can see they gave a comparison here. So it's slower than days prior. Normal volume, but they were speaking a lot, mildly pressured, like they were really trying to get out what they wanted to say. However, they were able to be interrupted. They were not in any distress, but they were unable to relate socially. So they would come up without any warning and kind of get into somebody's physical space. They would pat people on their medical team, asking personal questions, things that you wouldn't expect for that type of relationship. And then the range of affect was expansive. It was inappropriate to what they were describing. They were excited, mildly annoyed. So this was someone who was manic, and then this is the same patient, and they eventually ended up going to a different hospital, which happened to be Seattle Children's. And at that point, they were cooperative, in good behavioral control. Their speech was still hyperverbal, but it was a normal rate, so they weren't speaking as fast anymore. Affect was still a little bit expansive, but probably not as much as their initial presentation. And then still having grandiose delusions. But this shows, again, progression of time. So those mental status evaluations can change depending on how the patient is doing and who is evaluating them and for what purpose. These are some components, again, showing that the focus could be different. This is from Washington's CSHS office. They have minimal things that they really require to be in a mental status evaluation. You want to talk about someone's appearance, speech, attitude, behavior, mood, and affect. And then if something is not within normal limits, they want more detail on those things. So on the left shows you in Washington what is the minimum amount of information that should be included. But if there are other things that are not what you would expect, then they expect that you would put that into your mental status exam as well. The focus could differ as well because of the age. So there are some practice parameters. I included them at the end from the Journal of American Academy of Child and Adolescent Psychiatry, giving you ideas of how to evaluate at different ages. So this is an infant toddler mental status evaluation. It's more focused on the fact that there's going to be a lot of interactions between the parents and the child, and then how a child would react to an unfamiliar adult. You would want to involve play at that age because that is part of normal life for an infant and a toddler. And at this stage, you would want to put both normal and abnormal findings, unlike the Washington State minimum that really says hey, include these certain things, and then tack on some extra if it's abnormal. For children and adolescents, so this would be a bit older. The last one was infant toddler. You are still including how they would relate to whoever's examining them, how they relate to their parents, but you're also including more that you can get from speaking with the child, because at an early age, they don't have much in terms of verbal language. And you're also including a lot more about how they physically look to see if it could allude to any developmental delays, any genetic disorders. Some of the commonalities that exist between any state, any entity, any age are you always want to include physical appearance in your mental status evaluation, the attitude or the manner of either relating, playing, separating, something that is appropriate at that developmental stage of whatever age you're evaluating. Component of speech and language, some motor behavior, mood. So mood is what has been basically averaged, what has been occurring recently for this person. Have they been largely depressed? Have they been largely anxious? Have they been largely irritable? And then affect is what you see in the moment. So although they're describing ongoing depression, perhaps their affect is like jovial and excited and silly. You want to put thought process and thought content. So process is just how things connect to one another. Are their thoughts going in a line where it makes sense that one thought is leading to the next thought is leading to the next thought in a sequential order? Or is it the type of person who takes a long time to get to their point? Some people will call that circumferential, other people call it circumstantial. It's basically someone who beats around the bush. You might think of someone in your life who is a big storyteller, and the whole time they're talking, you're thinking, like, when are we going to get to the point? As opposed to someone who's tangential, where they're truly just going off on tangents and you're not really understanding where those thoughts are connecting. Eventually, they might kind of touch on something else, but they're not making too much sense. And then the other end of the spectrum is when someone's thought process is very loose or disorganized, where it really doesn't make any sense. Thoughts are not connecting to one another. You're very confused about what they're talking about. You can't really pick out a meaning of what they're saying. And then thought content really speaks to the content of what they're thinking about. Are they thinking about suicide? Are they thinking about homicide? Are they having any delusions, any hallucinations? Are they stuck or fixated on a particular thing over and over and over that they can't really stop talking about? Those would be the content of what their thoughts are. And then you usually speak about someone's executive functioning or intelligence or fund of knowledge or cognitive functioning or memory, some aspect of that. And you can always explain it in a way that's understandable to you. So you might say something like, average intellect, but I didn't do any formal testing, as opposed to someone that you might have done an actual cognitive test on, and then you can explain the results of it or what parts they had difficulty with and say what test you used. And you might do that for memory as well. You might just say they seem to have intact long-term memory because they can tell me about their family, where they're born, people in their life. Or you might actually test their short-term memory by asking them to remember a few different items for a few minutes. But you just want to speak to whatever you tested. Orientation, do they know where they are, who they are, some general facts. You cater it to however old they are, basically. So are they aware who their parent is if they're very young? Do they know that they're sick? As opposed to someone who's older, and you might be able to ask them questions like, what state do we live in? You can always check with their parent to see their baseline level of understanding. If someone is preschool age, they may not know when their birthday is, or they may not know what state they're in, and that's appropriate for them. So you can always check with their parent and say, hey, if they were feeling well, would they be able to say their full name or their birthday or that they're in a hospital? And then you can gauge their orientation off their parents' discussion of what their baseline is. Insight is how well do they have an understanding of what's going on? And you can describe it. It's always helpful to say why you're giving a term for how you're rating their insight or judgment. So if I said someone's insight was fair, I might say they have an understanding that they're at the hospital to be evaluated. They know that they've been feeling depressed. They think something might be going on with their health, as opposed to just saying insight poor. That doesn't really help anyone understand what was going on at the time. And then judgment is, what are their actions in the moment? If you're speaking about historical things, you should mention it, because a mental status evaluation is a snapshot right now. So if you're mentioning that they've had poor judgment recently, then you should say that. Judgment was poor immediately before coming to the hospital because they were destroying property. But judgment has been appropriate since here. They've been following the rules, they've been respectful to staff, whatever is appropriate in the moment. And then some mention of their attention and concentration. Are they able to focus and manipulate information in the moment, like hold on to things for a few seconds? That's attention. And then concentration is a longer level of understanding. Were they able to focus on an interview that you gave them while you were there for 30 minutes? There are many textbooks, some like Dulkin, which has a child and adolescent psychiatry textbook. They go through breakdowns of specific age ranges. So they have instructions for how to do a mental status evaluation in a preschool age. So that's between about 3 and right before someone is starting into kindergarten. Again, you still have a big emphasis on play. You want to describe how they're playing, what they're playing with, if they tend to return to certain things, if they're overly violent with their play, if they are acting out situations that seem like it could mirror what's happening at home. You want to say those things in your mental status evaluation. You can also comment while you're watching them play on their developmental functioning. So does it seem like they're able to pick up small pieces? Are they running around, seeming to be able to hop, to skip, to jump, bend down, pick things up? You can comment on their speech. Can they articulate themselves? Can you understand most of the words that they're saying? Do they have a large fund of words? Do they only have a few words that are intelligible? How do they sustain their play? Does it seem like they're jumping from thing to thing to thing for, manner of seconds, or are they able to sit for a few minutes? You can ask them kind of wondering questions like, oh, I wonder why the baby's crying while they're playing, to see how they respond to someone else engaging with them. And then you can also see their interactions with their primary caregiver. Does the caregiver engage them? Do they engage them back? How does the caregiver respond? And then you can also have them do a sort of structured task. So you could have them clean up so that they could get a sticker or a snack at the end. You could have them build a certain shape. You could have the caregiver step out while they're playing to see how they separate, tell them to wait in the hall for a few minutes and come back to see how they reunite. So you can get a lot from just watching a child play. I'm going to show a little bit of a video just to show some aspects of play that might demonstrate things that are concerning for autism, for example. Does it show up when I click this?
I took over.
Okay.
Give a thumbs up with the YouTube video. Great. I will go ahead and play it. Please let me know if you cannot hear.
This 19-month-old child shows signs of ASD. He has an intense interest in the toy phone. He does not share his enjoyment of the phone with others. He does not look toward others and smile.
Censor the old time. He really has to think he's so it's okay that he'll tell me to down, so probably like 10 cell phones laying around my house. So he walks around carrying them and puts them down and then he goes on to the next one.
Although he puts the phone to his ear, he does not show creative play with the phone. When his name is called, he does not respond.
Elliot. Ellie. Elliot.
He does not offer the phone to others so that they can have a turn.
Progressively, he's not.
His mother tries to distract his attention away from the phone.
The mom see the phone. The mom see it. The mom see the phone. There you are.
She begins to tickle him. Although he seems to enjoy the tickling, he does not look at his mother or make a social connection with her. He does not try to communicate with his mom to keep the social game going.
Okay, you can move on to the next one, Jasmine. So that was the Kennedy Krieger Institute has a lot of great videos. That was a structured play session in somebody's intake when they were observing with parents concerned for autism. We can play this one. This is an example of tardive dyskinesia. And this is something that you'd be able to explain well in a mental status evaluation. So watch her body movements as she's sitting in the chair. So her legs are almost continuously moving. She's having a lot of grimacing in her face and a lot of puckering. And she's doing something that's distracting her. She's watching TV, she's eating goldfish, and these movements are happening. We can go to the next slide. Okay, and then this is another video. Again, things that you'd be able to describe in a mental status evaluation when it's describing the motor portions. So most of these kids so far have had motor tics rather than verbal tics. So I don't think the sound had mattered that much. But one of the kids had kind of eye-opening and leaning his head back as his tic. I think this young man had an eye blinking tic. You can try to unmute it, Jasmine. Okay, we can move on from this. Most of them were motor, so I don't think the sound mattered all that much. But then I will go back to my slides. Okay, so we watched the video from Kennedy Krieger about an intake where they were observing play with a 15-month-old who they were concerned about autism. With him, there was a lot of focus on how he was playing, what themes he had when he was playing. They were talking about fine and gross motor skills. They were talking about interaction with caregivers, that he wasn't responding to his name, he wasn't making eye contact. How he was reuniting with the mom. He didn't seem overly concerned when she had left. When you progress up to elementary school age, there is still consideration for interaction with family, but sometimes the setting might be in school that they're being evaluated, so they won't have a parent immediately available necessarily. With behavior, it may talk more about cooperation, transitions, their level of flexibility, especially if they're having behavioral problems at school. How easy is it for them to transition between classes or preferred and non-preferred tasks? How are they able to relate to people? they are more able, usually 7 and up, they start to have an understanding of the finality of death. So that becomes more important of starting to ask suicide questions. They can have more of an understanding of what that would mean to die or to make themselves die forever. You're still talking about some aspect of evaluating their cognition. Might be talking more about impulse control at this age. Okay, Jasmine, what is the question?
There's a question in the chat, says, how is this aligned with taking perspective that though a child may be age 14, they are presenting younger? Is there a perspective that they are presenting at a lower age level than their actual age?
I guess it would depend on what context they were being seen. So there could be a person. Okay, I'm trying to read it as I do it so I remember. So their physical appearance might be older than their chronologic age or younger than their chronologic age. You can speak to their type of speech. So if someone is speaking in baby voices, basically, or using infant language like mama, dada, gaga, you can speak to that. And again, this is just a portion of your evaluation. So that may guide you then in thinking to yourself, why are they doing this? Is it perhaps a developmental delay? Are they having speech problems that make it so that they are speaking at what sounds to be a lower level than their chronologic age? Do they have intellectual disability where, although they are chronologically 14, they come across more like a 6 or 7-year-old? Or are they anxious? And could it be that they're very nervous around people that they don't know well? They regress, they speak as if they're much younger. Or could it be that they have some sort of precocious puberty? They look physically much older than they are. So I think, again, this is just a snapshot, a moment in time that is helping you to formulate your overall evaluation. And again, it's going to depend. So if someone went to, let's say, an endocrinologist, so like a hormone doctor, and the purpose was to evaluate for precocious puberty, they might focus a lot more on the physical aspects of why this person looks to be much older than their chronologic age. Or if they went to a counselor or therapist and their parent or the child's concern was they become mute and they don't speak because they're very uncomfortable in unfamiliar settings, then that would be something of a different focus. So I think it just depends with what's the focus, what am I trying to reiterate to myself or suss out when I'm formulating what the diagnosis is and how that's going to impact treatment. Does that answer the question? Tell me if it doesn't, Tally. We watched tardive dyskinesia. So this can happen when people are taking antipsychotic medicines. It can be involuntary movements. They can look jerky. There could be movements of the face where it looks like someone's puckering, like they've swallowed something sour. They could be drooling. They could have grimacing of their face. And that's something that we look for when we're prescribing and using certain medications. And it would be relevant because that could be something that would alert you to, oh, this is not a medication that we can take in the long run because they're having this occur already. And it would be a discussion of risks and benefits for that medicine. We watched a video about tics. Again, that would be something that would be relevant to put into the motor section of a mental status evaluation. Again, the way that I think of it is, if everything is going fine and dandy, then your mental status evaluation looks pretty boring. When there's things that matter in either pointing you in the right direction or ruling something out, you want to make sure it's evident there. So if I was concerned because a kiddo came in and his family said he's really disruptive in class, and then I noticed that they were having these physical movements that were akin to a tic, I would want to mention that because that might be interfering with him paying attention in class, might make them feel very self-conscious, or might just be overly distracting to other kids in class, and perhaps that's what's going on. So again, it deals with the focus of whatever you're evaluating and what the purpose of your evaluation is. For older kiddos, there's a larger emphasis on figuring themselves out. So yes, you still want to involve the parents, but especially in Washington at 13 and older, they have a lot more say in their mental health care. So one thing to think about is you still want to align with parents as much as you can, because they might not bring the kid to the appointment, or they might not bring the kid to see you anymore. And then you can discuss all of the aspects of confidentiality and what you can keep between the teen and yourself. Some meaningfulness, some things that might make sense to put in different aspects of the mental status evaluation. For appearance, if they had particular cuts on their body, if it was body piercings, if they were self-injuring, if they smelled of alcohol, those would be relevant depending on why you were evaluating them. Again, for behavior, if they're having tics, if they're pacing, if they're hitting themselves, if they're rocking, their attitude is how they relate to you. So are they overly flattering? Are they eager to please? Are they very uncooperative? Again, this could either speak to why they came in. It could give a sense of how they were at that time. And then maybe when you got to know them better, if they felt better rapport with you, perhaps the attitude could change. The description of somebody's mood would be euthymic is a normal display of mood. Hyper is intense. Dis is unease or dissatisfaction, so the negative. And then you can speak to the quality of it. Is it intense? Is it full? Does it seem like they really don't have much in terms of displaying their emotions? The motility is how it shifts. So if you thought of someone who had a labile mood, it would shift quickly and you wouldn't know what you were going to get, as opposed to stable where it's expected. And if they're talking about something sad, then they might be tearful. If they're excited and talking about an interest, they might be happy, as opposed to sluggish where you're kind of waiting for, oh, when are you going to get happy? Like you're talking about things that you really like. Their speech rate, you can describe that. That might be meaningful, especially if someone came in and you were evaluating for potential like bipolar disorder and you were trying to figure out if they were manic. And then if they have a dysarthria, so if they have a lisp or a stutter, that could be relevant. If they are repeating what you're saying, that also could be relevant because sometimes that can allude to neurologic problems or like serious mental illness. If they're making up new words, you could ask them why they're doing that. And this is more in terms of truly creating new words that often don't make sense, as opposed to like slang that we might not understand for being older. And then a clang association is a rhyming of words. It usually doesn't make any sense. So I saw someone previously who was manic and was just rhyming things like the shrimp and the pimp went in the truck, and I was at the store and the boar, and like it didn't make any sense. Again, some ways that you can describe things is if someone is, their thought process is goal directed, then it's moving in a line. They're not veering off the subject. Again, if they're tangential, they're just going off. You don't know what they're talking about. They're not answering your question. Perseveration is when they keep repeating the same response, they keep going back, or they keep talking about the same thing, even though you've tried to change the conversation. Thought blocking is when they're speaking and then they suddenly stop and it's like they can't get the rest of that thought out. A delusion, fixed false belief. So even when people are providing evidence to state the otherwise, they still think it's true. So it might be paranoia that someone is hiding in their house and they just, despite what you say, however much evidence you give them, they won't stop believing. And then a lot of kids talk about depersonalization, feeling like they're not themselves, as opposed to derealization, where it feels like everything else is not real. And then sometimes people will talk about hallucinations, and there are some normal hallucinations, hypnagogic when you're going to sleep and hypnopumpic when you're waking up. It's just a normal state of going in and out of REM sleep where you may have some hallucinations. And that's very different than if someone is standing in the middle of their classroom and they're hearing something talking to them and there's nobody else in the room. Again, these are just ways that you can describe things. And then I think this is the last video for mental status evaluation. Pay attention to what the child is saying. And then the parent was describing a much different presentation. So the parent was saying this child is failing classes. They got detention for throwing a ball at a peer's head. And then this is an example of a girl who is manic. I think you have to do it, Jasmine. And you can see a much different picture when you're just watching her.
Give me a thumbs up if you can hear the sound. Okay, 1 second. I'm going to restart it.
Rebecca, how old are you?
I'm 12.
Did you just think of something funny?
Not really.
And how are you doing in school?
Awesome. We had a race in PE, and I ran faster than anyone else in the grade. I think I broke the school record. I ran into one of those hurdle things and went splat on the ground. Everybody was freaking out.
Did you hurt yourself?
There was some blood, but I like to see blood. It's really cool.
And how are you doing in class?
Real good. The work is super easy.
Your mom says you're failing a lot of classes.
Teachers don't know how to teach. I tell them I did all my work, and they say that is wrong. What do they know?
Do you get in a lot of arguments with adults?
No, they get in arguments with me. Do you know that song that goes, I like going 3 tomatoes?
I do not. Have you been getting in trouble at home?
No.
And your mom says you got grounded for throwing a ball at her head.
That was just a joke.
Let me ask you about your moods. Do you always feel as good as you do right now?
Oh, yeah.
And how long has that been going on?
Forever.
And how do you feel about yourself? Do you like yourself?
I'm a great dancer. I'm going to be the star of the school musical.
And do you have any other special talents, things other people don't have?
When I close my eyes, I can hear people's thoughts.
And what do you hear?
I can hear the teacher saying she's not going to make me take the test because I know it already.
And is it like a voice out loud in your head?
Sometimes.
Are you hearing it now?
No.
Do you have a lot of energy?
My mom says I'm the Energizer Bunny.
Very good. Do you do that in class?
Oh, yeah, it's so funny. When I dance, it's a fancy dance. A fancy, fancy dance.
Whoop.
Ugh, I hate this. Stupid thing is broken. My mom is always buying me junk.
Let me have a look. Here, I think I've got it.
Great, thanks.
Okay. So that was an example of somebody who was manic. It's always important to get collateral information. That doesn't necessarily go into the mental status evaluation, but it helps you with your overall evaluation. So the child had a much different idea of what was going on as compared to the guardian. And then obviously, if you would have just listened to the words that they said, the child said they were doing great in school. It was the teacher who had the problems. You may have gotten a much different outcome than if you actually observed them and did a mental status evaluation. So again, with that video, like her attitude, her behavior, she was very cooperative, maybe overly familiar with the interviewer. Her behavior was somewhat impulsive, appropriate style of dress. Her speech was hyperverbal. She was pressured at times. Her motor, she was dancing randomly. She threw her iPod at one time. The orientation, they didn't go over in there, but it seemingly seemed like she knew where she was. She was there for an evaluation. Her affect, was labile. She was angry one moment and irritated with teachers in the iPod. She was happy the next. She was giggling. Mood overall, she said it had been great. They didn't talk about SI or HI. Her thought content, was she described some delusions that she was better than everybody. Also some like ideas of reference that the teacher was sending her messages. Perceptions, she described having some auditory hallucinations at times. And then they didn't touch on memory or intellectual functioning or abstraction. Her judgment seemed to be limited. She jumped up without prompting, threw something in the middle of the interview. Her insight seemed poor. She didn't know why she was doing so poorly in school. So again, by watching her, we can fill out our entire mental status evaluation, and it helps us against or in addition to whatever the collateral is. Some conundrums that we often have are a basic level of trust is needed. There's often times when teenagers say that they're not going to talk to you. They will sometimes refuse. They'll just be cursing or agitated or put you in a situation where you can't physically do it. You can do your best. So you can describe a situation just by observing. And I always tell people, write it as if you're writing stage directions or a play. Just write it in whatever detail you can. You don't have to use any particularly fancy words to describe things so long as you describe it. It's going to be subjective. It will be different because there's different providers who have a different level of interaction. Maybe their focus is different. Maybe they're seeing them at a different state in time. They could be sedated. They could be intoxicated. For me, there are times when I will still evaluate someone while they're intoxicated or drunk because it will matter for their treatment, especially if they're going to need treatment because we're concerned about alcohol withdrawal. If they have an intellectual disability or neurologic disorder, that can be challenging because they might not be able to meaningfully participate. Again, you can still state whatever it is that you're seeing. They might not understand questions that you ask. There might be language barriers. They might be sleep deprived. They might just be medically sick. This is very teeny, but I'm going to give you the high points. So this is an example of a 25-year-old Black female. She appears stated age. She's wearing paper hospital scrubs. She has cut them to expose her abdomen. She has a vertical scar, tattoos of various names on forearms. She is inappropriately laughing and smiling. She has some agitation, but she doesn't have any tics or tremors. Hyperverbal, her tone seems happy. She describes her mood as fantastic, and she seems inappropriate. She's having flight of ideas. She's talking about many different things and some grandiose delusions that she's an angel on a mission. She has auditory hallucinations of God commanding her to go to California. And then they talk about her attention and concentration. So one way to test somebody's attention is you can have them spell a word. A lot of the times they'll use world because there are no repeating letters. So someone has to be able to spell it forwards first. You need to make certain that they can spell it in general. And then they have to have some sort of attention to be able to manipulate it in their mind and give you the letters backwards. Other people will do strings of numbers. And then sometimes with smaller kids, I'll have them squeeze my hand. So I'll ask them for a certain letter and I'll say, pay attention. You're only going to want to squeeze my hand when you hear the letter C. And then I'll give them a string that's at least this long. So at least 5 or more where I put C strewn throughout there, and they have to pay attention to be able to squeeze it only when they hear C. A way to test memory, she was able to recall objects immediately, and then after a minute when she was given some objects, so sometimes I'll say apple, table, and penny, and I'll have the person state it back to me and then wait a few minutes, ask them to do it again. Recent memory, you can speak to nursing staff about what they've eaten recently or talk to teachers about what they brought to school with them. And then long-term memory, you're often going to need to speak with a caregiver. And then in this case, this person had some abstract reasoning at her age. She could make comparisons between things. Her insight was poor, her judgment was poor. So that was an example of somebody with bipolar 1 disorder who was currently manic, and she was on an inpatient psychiatry unit. Again, it talks about the high points of her mental status evaluation that were meaningful. And this person was in an inpatient psychiatry unit. They'd been diagnosed with bipolar while they were there. So then Here is the same mental status exam, same patient, but someone's gathered more information. So now she's presenting to an urgent care facility. The context is she's marginalized. She's having inappropriate laughter, which actually seems like a trauma or anxiety reaction because she's had a lot of distrust in the healthcare system in the past. The psychosis only just started. She was leaving a highly religious community. And then she also had a positive UDS. So because of the situation and the focus of the mental status exam, there was a different outcome. First one, it was in a psychiatry unit. They were evaluating for a diagnosis. They came to what that diagnosis was by recurrently examining, doing mental status exams, comparing them, seeing how she progressed, as opposed to this situation where it was a different focus. She showed up to an urgent care facility. It seemed that she had just come from this highly religious community and she had been using drugs or alcohol, so she was intoxicated. They could wait until she was no longer intoxicated, and then she was having less of this reaction, still some trauma reaction, and she was able to go home soon afterwards. So there will always be some underlying bias towards people with mental illness as best we try. The point of the mental status exam is, again, to try your best at an objective evaluation. There are often times when marginalized people end up with more diagnoses than others, people blaming crimes. There could be issues with stigma. It could be a mismatch between provider and patient. But all of these things need to be gathered. There needs to be standardization between people, and you need to keep it in your mind that there might be bias so that you feel that you're appropriately evaluating and diagnosing people. Some other examples just of pertinent things that you might find in mental status evaluations. Someone could have congenital deformities. They could have no spontaneous speech for many different reasons. Perhaps they have a speech delay. They might have selective mutism. All of these things matter and are worth putting in your mental status exam as you're trying to kind of figure out the picture of a patient. There is another example of someone who had developmental delays and a genetic disorder who had intellectual disability at baseline. And again, it mattered for the motor behavior that she was showing. She had echopraxia, which was mimicking other people's behaviors, like physical movements. So if I put my hand up, she'd put her hand up. And she started holding a stuffed pig up to her ear like a phone when other people would be on the phone in the room. And it was very important to get collateral information because her dad said that's what she does at home. She loves pretending with phones. It's not unusual for her. And again, it's relevant to put it in your mental status exam because someone stated this is the baseline and who it was that stated that, whether it was a well-known person who's reliable or not. So these are the references for items that are within that first portion of this mental status evaluation. People will get the slides. You can go to any of these. They're different resources. Some of them have videos or examples. And yeah, reference whatever you would like that makes your life easier or explains something better. And then we're going to move on to part 2. I don't think I put any videos in this part, so hopefully it's a little bit easier. But this component is about anxiety. Again, we're going to talk about theories, diagnoses, and then potential treatments or techniques or thoughts about anxiety. So anxiety in general, it's one of the most common groups of psychiatric disorders. 1 in 4 people have an anxiety disorder, more women than men. Fear is different than anxiety. So fear is a response to a known, external, and definite stimulus. It is a threat. It is something that if the vast majority of people looked at this thing, they would say that that poses a threat. And appropriately, we have fear in response to that. So if I am about to cross the street and everybody looks and sees a car coming, I am scared because that could be a threat to me and everybody can agree on that. As opposed to anxiety, which is a response to a threat that's unknown or internal or vague or conflictual. So this could be me going into work and suddenly becoming anxious because I think there's going to be a threat of having to speak in front of people. And that is not something that everybody would find to be a threat. And it's something that's inside of me. It's not something that's going to attack me. So that is anxiety. There's significant morbidity, aka a lot of people get it. It tends to be chronic, and at times it can be resistant to treatment. There's a lot of different theories about what makes for anxiety, and there's often genetic as well as experience that go into it. If you took everybody in the world who had anxiety, the median age would be 6 for a specific phobia, 8 for separation anxiety, 12 for social anxiety, and then more teenage years for generalized anxiety disorder. So knowing those certain age brackets for things, it kind of makes you more aware of it in those age groups. So you might just look for it more. Is it a big deal? So there are certain typical fears or worries that happen, but they're expected at particular developmental times and they do not persist. They occur during that expected time and they don't go on. So with infants and toddlers, there could be anxiety with loud noises, especially if it's a newborn. You may have the startle response where a loud noise makes their whole body shake, like their arms go out, their legs go out. That is an expected thing. Predictable separations from parents, the first time a babysitter comes, the first time they get dropped off at daycare, those are expected things. We don't expect that they're going to go on. Preschoolers, some of their typical fears are imaginary monsters, darkness, heights. Middle school, they start to worry about injuries, storms, insects. And then early adolescence tends to be more social items. So competence, how they're going to be evaluated by other people, how their relationships are going, how well they're doing in school, or having to do things in front of other people. The vast majority of kids have their first anxiety disorder symptoms before puberty. And then the parents might start to notice that what they really used to like starts to make for a big reaction, and that's when families get concerned. So they might have physical symptoms, especially school age, headaches, chest pain, nausea, going to the school nurse a lot. Those can be the first signs that there might be anxiety kind of lurking. Some of the theories about why anxiety exists, there are psychoanalytic theories where it's a signal of danger in the unconscious, and then there's a conflict that occurs. So the goal is to increase tolerance to that anxiety to get you through that conflict at a particular developmental level. There's behavioral theories. So this is the kind of Pavlovian response. When the dogs would salivate when they would hear a bell ringing, this is similar concept. So people become conditioned to certain stimuli in the environment, and that then causes anxiety because they get used to anxiety occurring when that thing happens. Existential, feeling that they're living in a purposeless universe. Biologic, there's autonomic happenings like increased heart rate, headache, diarrhea. There's neurotransmitters involved, and then there's the hypothalamic pituitary adrenal axis that releases basically adrenaline. And then in this instance, that's where benzodiazepines act as the treatment because they're basically acting on that GABA receptor, which quiets stuff down. There can be genetic instances of anxiety. They have twin studies that show that there's at least a partial genetic determination, but it's not a single gene. It just shows that there's relations in family. And then neuroanatomy, the limbic system has a higher concentration of a particular GABA receptor, and a lot of serotonin innervation and norepinephrine. So it basically leads to a lot more of that adrenaline response. There's neurobiology of anxiety disorder. Some people find that there are both structural and functional abnormalities in brain regions. So that can lead to hyperreactivity and retreat from new things. So anticipating if something is new, that it's going to have an uncomfortable response and you become much more reactive to it. And that in turn can activate certain portions of the brain, certain hormonal systems in the body, and that can prime the development of an anxiety disorder. And there are other networks in your brain that basically mean these threats become more obvious. You pay more attention to them, although it's not actually a credible threat that would cause fear. And then that starts to come up with a representation of yourself and what may happen in the future in a negative way. So it's like that thing is broadcast through your brain and becomes the prominent aspect. And that plus these underlying primed systems can lead to a lot more anxiety in certain people. Some risk factors: family history. Anxiety tends to run in families. Again, there could be an attention bias towards certain stimuli, feeling like, oh, because it's new, I'm not going to like it. There could be behavioral inhibition, you feel overwhelmed, you withdraw from unfamiliar settings or people. It could be attachment, so an anxious attachment between a caregiver and a child, childhood separation related events, immigration, refugees. There can be a lot of attachment issues. Parenting style, there tends to be overprotectiveness, psychological control, and then modeling anxiousness, basically. So if a child is watching an anxious parent who's continually not doing new things or becoming very threatened by new situations, new people, they're watching that happen. They're assuming that's how it should happen. And then they sometimes are also modeling what could be ineffective coping strategies like avoidance. If they're watching a parent who starts to get anxious and just doesn't go somewhere, they may think, oh, that's how you do it. When you start to get nervous, you just avoid it. This is often subconscious, but they're watching it, and children learn a whole lot from modeling. There's also a lot of family accommodation. So families tend to adapt their day-to-day with an anxious child. They will avoid things because they're worried that the child's going to have a reaction. They could adapt things. They change their plans. They change their vacations. They change school schedules. There's a lot of accommodation that occurs. And then another risk factor is alcohol, tobacco, and cannabis. So there are studies that show regular daily cannabis use in teens increases the risk for developing anxiety disorders. So there's a ton of different anxiety disorders. We're not going to touch on every single one. Again, there are certain ones that tend to crop up in different ages. So if you work with a particular population, you might just pick it out and say, oh, this is one I should keep my eye out for because it tends to occur in my age group that I treat or that I interact with. Separation anxiety disorder. Now, in DSM-5, they've changed the diagnostic criteria. So separation anxiety goes both ways. It can be from child to parent. It can also be from parent to child. This is when it's developmentally inappropriate. That's when you start to talk about a separation anxiety disorder. If you're talking about an infant or a toddler, that is expected and appropriate developmentally for them to be nervous when their caregiver leaves them. So these are the criteria. You have normal separation anxiety, where we expect it, we accept it, we think it's going to happen, anywhere from 8 months to 3 years old. So typically, right near walking age until about preschoolish. Selective mutism, mostly in young children. Every once in a while, it can happen in older, but it's consistent failure to speak in specific situations. But they'll speak in other situations, and it tends to get in the way of schooling or friendships. Has to have been occurring for at least a month. And if there is any lack of knowledge or lack of comfort with the spoken language, that's something else. That's just a lack of comfort or a lack of knowledge. Perhaps they're learning English as a second language, or they have a dual language family. You always want to check into it to make certain that this isn't the reason that they're not speaking. And then it's also not better explained by a communication disorder. So if someone has a lisp, a stutter, and that's the reason that they're not speaking in certain situations, then that's different than selective mutism. Specific phobias, again, one of the most common mental disorders in the US. The peak is between 5 and 9 years old, tends to run in families, and then it's really remarkable fear about a certain object or situation. There could be animal type, natural environment type, blood, injection, injury type, situational, or some kind of lumped in other ones like loud sounds, choking or vomiting. Social anxiety disorder, fear of embarrassment in public, embarrassment that may occur in the situation. And then these kids tend to have a pattern of behavioral inhibition. So again, not wanting to go and try new things. Has to have been occurring for over 6 months and has to be functionally impairing. So make so that they can't go to do things they want to do, interfering with their family life. Panic disorder is recurrent unexpected panic attacks. It tends to reach its peak within a couple minutes, and then you have to have 4 of these physical symptoms that happen. It cannot be due to substance use, and you have to have at least an attack that's been followed by persistent concern or worry about having more, or significant changes in behavior related to the attacks. So maybe they've stopped going to a certain place because they're worried they're going to have another one, or they won't leave the house for a bit. They won't go to school because they're worried that someone's going to witness a panic attack. Agoraphobia. This is basically the fear of going out. This is different because they're thinking that escape might be difficult, not because they're going to have a panic attack out in this place necessarily, but that they're going to be trapped. And then it has to occur in various situations, not only social situations, or we would call it probably social anxiety disorder. So again, you're kind of looking for what are the complaints that they're talking about? What situations do they occur in? What is it preventing them from doing to try to narrow down what disorder it probably fits into best? And the whole reason of clarifying somebody's diagnosis is so that you can give them a clear treatment path. And I tend to describe it to kids by, you're going to tell me about a whole bunch of different symptoms, and I'm going to work with you to try to lump it together into a certain name. And the only reason that I care about the name is so that I can suggest treatment. Whatever the name means to them is whatever the name means to them. If they like having a certain name to explain what's going on, great. If they don't like having a label, that's fine. In my mind, it's just a word to describe how we're going to treat it. Generalized anxiety disorder probably has the highest comorbidity with other mental health disorders. There's a mnemonic, so oftentimes people think of depression with the mnemonic SIGI CAPS to describe the symptoms. This has a different mnemonic that people have come up with. And I see rest. So you need all of the ones that make up the and then 3 of the other ones at least. This has to happen near daily for at least 6 months. And then only 1 of the 6 symptoms is required in kids. So it's pretty inclusive for children. If you're not sure of what's going on, but you have suspicions, you can use screeners. Screeners, the word should explain it. It just screens for something. It does not diagnose anything. It just screens to say, hey, there's a concern for this thing. Let's look at it more. So screeners should only supplement your diagnostic criteria. It can help you if you're kind of on the fence about what's going on. It can never be the sole method of diagnosing someone with something. It can also help with treatment response. So at times there are families, kids who have a really hard time describing what's going on. And sometimes it's helpful for them to see numerical responses. So if they have anxiety, perhaps generalized anxiety disorder, and they're presented with a screener called the GAD-7, you might show them where they're at each visit, or every month you can show them how their symptoms have changed, and that can be somewhat reassuring to them that treatment is working. Or you might be able to then go back to the drawing board. If you feel like nothing's budging, you might think to yourself, do I have the correct diagnosis? Should we go back and look for something else? And then the scared questionnaire is kind of an inclusive anxiety screen. I find it to be a little time consuming. I'm sure some people are like really good at it and they whip them out real quick, but it has a parent version, a child version, so you can get different perspectives, and it goes over many different types of anxiety. There are sometimes medical causes of anxiety. They're fairly rare though. Hyperthyroidism can make people have panic attacks having high thyroid levels. Hypoglycemia can cause things that might mimic anxiety, like tremor, tachycardia, sweating. Pheochromocytoma can sometimes cause headaches, sweating, hypertension, changes in parathyroid gland, asthma, which can cause shortness of breath, increased heart rate, restless leg syndrome, which might just make it hard for someone to fall asleep at night and then might lead to irritability and kind of a racing mind. Iron deficiency, B12 deficiencies, and then sometimes corticosteroids. Again, these could be things that you would ask about, but you don't see them quite as often. So there's no specific like lab workup or anything that's standard of care. But if they have other things going on, you might ask them to see their doctor to make sure that there's no medical reason for their anxiety. And then the treatment of anxiety is based upon the diagnosis. So again, I'm telling kids, hey, we're going to go through all these symptoms. I'm going to give it a name just to lead me towards my treatment. So if there's mild and sometimes moderate anxiety, then cognitive behavioral therapy tends to be the treatment of choice. And that tends to include exposure. Again, because there's a high behavioral, I guess, slant towards the theories of what causes it. So in anxiety, there tends to be a lot of avoidance. They don't want to do things. They're behaviorally inhibited. They don't want to try new things. They have a family that's accommodating. They're avoiding a lot of things. So exposure is often a means of treating the anxiety, to show them ways to reduce their anxiety where they're feeling comfortable and showing them that they can go through these experiences and be okay. And then when it gets to moderate or severe anxiety, there will sometimes be the addition of a medication. If there's only a partial response to therapy after trying it for a while, that may be a time to introduce medication. If there's comorbidities, if it's severe anxiety where the person is saying, I can't even imagine doing therapy, like this feels overwhelming, then maybe it's worth starting a medication earlier so that they can get over the hump and really engage with the therapist. So I don't think I put any others. These are the references from this. If anybody has any questions, I can answer them. I wanted to make sure to leave time to do so. And then all of the slides will get sent out and this stuff will be posted to recorded so that people can listen or go back.
Thank you so much, Dr. Rensko. So like she said, if you have any questions, I have updated the site, so you should be able to unmute yourself. If you're not, raise your hand and I can unmute you. But we want to make sure that you have any questions that they get answered. I don't see any additional ones in the chat other than the ones that were already shared out. I'm just doing a quick look to make sure I didn't miss any. Nope. Like she said, it looks like, oh, thank you for that, Eddie. Are you talking about the form or the allowing you to unmute? Okay, I'll update that. Thank you for letting me know. The other thing I wanted to share is if you haven't registered, tomorrow will be the part 2. And so it will go over depression and another disorder, and we'll be meeting same time, different registration link. So please make sure to register for that one if you haven't already. Like Dr. Rensko mentioned, they will be there we go. It should update now. So those that are not within Multicare, you should be able to access that link now. The recording will be posted in the team site, so you have immediate access if you were registered or you attended today. It will also be posted to the Kids Mental Health Pierce County website. So once we get that available on the website, we will let those that are unable to access it again through Teams be able to access it on the Kids Mental Health Pierce County website. If you don't have any other questions or needs, feel free to jump off, but we appreciate your time and thanks so much for joining us. Looks like Jamie has a question here. Have you seen an increase in anxiety in children in recent years?
I think if research pulled numbers, there would probably not be an increase, but I think a lot of children are just much more willing to talk about mental health. And it's much more accepted. Kids talk about it with each other. There's more presence in schools where kids are actually using their school counselors appropriately. So I think families bring them more, and families are more open to recognizing that there is anxiety, as opposed to years ago. If you talk to other people throughout your life who are perhaps older in age, they'll say, oh, that wasn't anxiety. Or they'll use a lot of comments like Hispanic people don't have anxiety, Black people don't have anxiety. That's just, and they'll explain kind of challenges in their life that someone else may call anxiety. So I think verbiage has changed where people are trying to be much more understanding and decrease the stigma. And there might just be more kids willing to say the words anxiety, and families believe the words anxiety.
Another question in chat was regarding CEUs. Unfortunately, we are not able to provide continuing education units for this training series, but we hope to be able to in the future. Any other last minute questions? I don't see anyone coming off mute or any hands. Feel free to add them to the chat or come off mute if you can. All right, well, I will go ahead and conclude the training. Thank you guys so much. Again, I'll put the registration link for tomorrow's training here in the chat if you haven't registered yet. Thank you to those that have been able to fill out the evaluation, and we hope to see you tomorrow. Have a great day.